Hey everyone, hope you're having a great day. You're listening to the RX Daily Dose. Today's episode is being recorded for Monday, August 17th, and I'm your host, Ian Parnagoni. We update this podcast for healthcare providers, medical professionals, and anyone who has an interest in drug updates. Don't forget to like, share, and subscribe on all your favorite podcast platforms and social media, including iTunes, Spotify, YouTube, and Instagram. All links can be found in the show notes below. In today's episode, we're going to talk about the approval of Monjuvi for B-cell lymphoma, Lampet for Chagas disease, and Evrysdi for spinal muscular atrophy. We also have approval of Blenrep for multiple myeloma and Viltepso for Duchenne muscular dystrophy. As always, feel free to skip around. I'm going to include times in the show notes so you can get the drugs that interest you. First this week, the FDA granted accelerated approval to tafasitamab, which goes by brand name Monjuvi, a CD19-directed cytolytic antibody indicated in combination with Revlimid for adult patients with relapsed or refractory diffuse large B-cell lymphoma, which goes by acronym DLBCL, that is not otherwise specified, including DLBCL arising from low-grade lymphoma and who are not eligible for autologous stem cell transplant. The efficacy of Monjuvi with Revlimid was evaluated in the L-MIND trial, an open-label, multi-center, single-arm trial with 81 patients. Patients received Monjuvi 12 milligrams per kilogram IV with Revlimid for a maximum of 12 cycles, followed by Monjuvi as monotherapy. Efficacy was based on overall response rate, defined as complete and partial responders, and response duration as assessed by an independent review committee. The best overall response rate in 71 patients with a diagnosis of DLBCL confirmed by central pathology was 55%, with complete responses in 37% and partial responses in 18% of patients. Median response duration was 21.7 months. The most common adverse reactions were blood dyscrasias, including neutropenia, anemia, and thrombocytopenia, as well as fatigue, diarrhea, fever, and peripheral edema. The recommended Monjuvi dose is 12 milligrams per kilogram as an IV infusion. The FDA also approved Bayer's Nifurtimox tablets, which go by brand name Lampet, for treating Chagas disease in pediatric patients younger than 18 years, including newborns weighing at least 2.5 kilograms. Chagas is an infectious tropical disease caused by the Trypanosoma cruzi parasite, transmitted to humans mainly in the feces of infected insects, but also mother to child during pregnancy and birth, and through blood transfusions or organ transplant. Lampet's approval was based on efficacy, safety, and pharmacokinetic findings from the Phase 3 prospective CHICO study in 330 children with Chagas disease at sites in Argentina, Bolivia, and Colombia. The children were randomly assigned to receive a 60 or 30-day treatment regimen and followed up a year after treatment cessation. Serologic response showed superiority in the 60-day arm over the 30-day arm. Children will be followed for another 3 years to confirm the study drug's efficacy and safety. Because the drug received accelerated approval, its continued approval for this indication will depend on demonstration of clinical benefit in confirmatory studies. Lampet is currently registered in Argentina, Chile, El Salvador, Guatemala, Honduras, and Uruguay for the treatment of acute and chronic Chagas disease in adults and children. It was first introduced by Bayer in the 1970s and is on the World Health Organization list of essential medicines. The FDA also approved Risdiplam, which goes by brand name Evrysdi, to treat patients 2 months of age and older with spinal muscular atrophy, a rare and often fatal genetic disease affecting muscle strength and movement. This is the second drug and the first oral drug approved to treat the disease. Spinal muscular atrophy is a hereditary disease that causes weakness and muscle wasting because patients lose lower motor neurons that control movement. Evrysdi contains a survival of motor neuron 2 directed RNA splicing modifier. The efficacy of Evrysdi for the treatment of patients with infantile onset and later onset SMA was evaluated in 2 clinical studies. The infantile onset SMA study included 21 patients who had an average age of 6.7 months when the study began. In that open-label study, efficacy was established based on the ability to sit without support for at least 5 seconds and survival without permanent ventilation. After 12 months of treatment, 41% of patients were able to sit independently for more than 5 seconds, a meaningful difference from the natural progression of the disease because almost all untreated infants with infantile onset SMA cannot sit independently. After 23 or more months of treatment, 81% of patients were alive without permanent ventilation, which is a noticeable improvement from typical disease progression without treatment. Patients with later onset SMA were evaluated in a second randomized placebo-controlled study. The study included 180 patients with SMA aged 2 to 25 years. The primary endpoint was the change from baseline in a standardized motor function test at the 1-year mark. Patients on Evrysdi saw an average 1.36 increase in their score at the 1-year mark, compared to a 0.19 decrease in patients on placebo. The most common side effects of Evrysdi include fever, diarrhea, rash, ulcers of the mouth, joint pain, and urinary tract infections. Patients with infantile onset SMA had similar side effects as individuals with later onset SMA. Additional side effects for the infantile onset population include upper respiratory tract infection, pneumonia, constipation, and vomiting. Patients should avoid taking Evrysdi together with drugs that are multi-drug and toxin extrusion substrates, because Evrysdi may increase plasma concentrations of these drugs. The FDA granted this application Fast Track designation and priority review. The drug also received Orphan Drug designation, which provides incentives to assist and encourage drug development for rare diseases. The application was also awarded a Rare Pediatric Disease Priority Review voucher from the FDA. The FDA also approved GSK's belantamab mafodotin, which goes by brand name Blenrep, an injection for relapsed or refractory multiple myeloma in adults with previous failed treatments, including an immunomodulatory agent, proteasome inhibitor, and anti-CD38 antibody. Blenrep is the first anti-B cell maturation antigen therapy to receive approval anywhere in the world. Accelerated approval was based on response rate. The drug's continued approval for this indication will depend on clinical benefit findings in confirmatory trials. The drug's efficacy, based on overall response rate and response duration, was evaluated in the open-label, multi-center DREAM2 trial. Patients received either the recommended dose of 2.5 milligrams per kilogram of the study drug or 3.4 milligrams every 3 weeks, until disease progression or extreme toxicity. Patients receiving the 2.5 milligram dose showed an overall response rate of 31%, with 73% of responders in the group having response durations of 6 months or longer. Blenrep comes with a boxed warning for risk for ocular toxicity, so it will be available only under a REMS safety program. The review process and timeline were aided by use of the real-time oncology review, which facilitates pre-application data submission and the assessment aid. Blenrep carried orphan drug and breakthrough therapy designations and received priority review for this indication. The FDA also granted accelerated approval for Viltepso, which goes by brand name Viltepso, an injection for the treatment of Duchenne muscular dystrophy in patients who have a confirmed mutation of the DMD gene that is amenable to exon 53 skipping. This is the second FDA-approved targeted treatment for patients with this type of mutation. Approximately 8% of patients with DMD have a mutation that is amenable to exon 53 skipping. DMD is a rare genetic disorder characterized by progressive muscle deterioration and weakness. It is the most common type of muscular dystrophy. DMD is caused by mutations in the DMD gene that results in an absence of dystrophin, a protein that helps keep muscle cells intact. The first symptoms are usually seen between 3 and 5 years of age and worsen over time. DMD occurs in approximately 1 out of every 3,600 male infants worldwide. In rare cases, it can also affect females. Viltepso was evaluated in 2 clinical studies with a total of 32 patients, all of whom were male and had genetically confirmed DMD. The increase in dystrophin production was established in one of those 2 studies, a study that included 16 DMD patients, with 8 patients receiving Viltepso at the recommended dose. In the study, dystrophin levels increased on average from 0.6% of normal at baseline to 5.9% of normal at week 25. The FDA concluded that the applicant's data demonstrated an increase in dystrophin production that is reasonably likely to predict clinical benefit in patients with DMD who have a confirmed mutation of the dystrophin gene amenable to exon 53 skipping. A clinical benefit of the drug was not established in the study. In making the decision, the FDA considered the potential risks associated with the drug, the life-threatening and debilitating nature of the disease, and the lack of available therapies. As part of the accelerated approval process, the FDA is requiring the company to conduct a clinical trial to confirm the drug's clinical benefit. The ongoing study is designed to assess whether Viltepso improves the time to stand for DMD patients with this confirmed mutation. If the trial fails to verify clinical benefit, the FDA may initiate proceedings to withdraw the approval of the drug. The most common side effects observed in DMD patients treated with 80 milligrams per kilogram once a week were upper respiratory tract infection, injection site reaction, cough, and fever. Although kidney toxicity was not observed in the Viltepso clinical studies, the clinical experience with Viltepso is limited, and kidney toxicity, including potentially life-threatening glomerulonephritis, has been observed after administration of some antisense oligonucleotides. Kidney function should be monitored in patients taking Viltepso. Viltepso was approved under the FDA's accelerated approval pathway, which provides for the approval of drugs that treat serious or life-threatening diseases and generally offer a meaningful advantage over existing treatments. Approval under this pathway can be based on adequate and well-controlled studies showing the drug has an effect on a surrogate endpoint that is reasonably likely to predict clinical benefit to patients. This pathway provides earlier patient access to promising new drugs, while the company conducts clinical trials to verify the predicted clinical benefit. And that's all I have for right now. I hope you enjoyed today's episode. I'll include all links in the show notes below, so please go back and check those out too. Please connect with me on any of your social media platforms and give me feedback on what you heard today. I'd love to know what you thought about the episode. And as always, feel free to like, share, and subscribe wherever you listen to your podcasts. And thank you so much for tuning in. I hope you enjoy the rest of your day.